Today we're going to talk about the etiology of ischemic stroke. So by definition, it's basically when blood reaches improperly or insufficiently to a particular area of brain, it causes damage to the brain cells. So it's the easiest definition by how we can define the condition of ischemic stroke. So when you'll be out in your fields, you'll come across a lot of patients who'd come up to you in the emergency departments usually with a history of fall, or either there will be a history of unconsciousness that would be obviously given by the relatives or by the bypassers who brought the patient to the outpatient departments or to the emergency departments. So when you have these patients and you want to investigate these patients just to know the etiology behind this incidence of stroke, you're going to have a differential diagnosis in your mind. Obviously, the examination or how you go about the management of these cases starts off right off from the history, a particular history and a particular detailed history, which is, if possible, taken by the patient himself or herself, or either it can be a corroborative history from the friends or the relatives or even the bypassers who observed the case closely. So this is how you're going to enhance the case by just jotting down the points of the presenting complaints as well as the history of presenting complaints. For instance, if it was a case that basically encompassed the unconsciousness, you're going to just jot down whether this unconsciousness was followed by any attack of seizures or epilepsy if they were noted down by the bypassers, and you're going to note down these factors and any previous history of the patient as well, if that can be highlighted, of course. You're going to emphasize on these factors, and that is going to lead the case in a particular direction. Now, when you have determined or when you have diagnosed a person to be suffering from ischemic stroke, as we all know, we basically have these two major varieties of stroke encompassing primarily the ischemic stroke on one hand, and then we have the hemorrhagic stroke on the other hand. So we have these two different entities clinically that we have to examine and we have to basically diagnose in a particular case. So you should be quite sure what you're dealing with. Either it is an ischemic variety or either it is a hemorrhagic variety, because the management guidelines are entirely different in both of these cases. So it's again very important to distinguish just right from the start what you're looking for. And then obviously you're going to go about and look for the pathophysiological factors as well as the etiological factors in this particular case of ischemic stroke. So obviously, when you look for the factors of ischemic stroke, you know that what are we looking for and why is it important to look for these factors? Why is it important to investigate what caused the ischemic stroke in the very first place? Whether it was a disorder of the blood or whether it was an embolism or a thrombus that traveled from the peripheral circulation and entered the cerebral circulation eventually and led to the happening of the cerebrovascular accident in this particular case of a patient. Because that is going to highlight the factors how we are going to manage this particular case. The secondary prevention of the stroke in that particular patient, how you're going to design the management for that particular patient is going to rely upon these factors. So talking about the most important causative factors that leads to the incidence of cerebrovascular accidents, particularly the type of the ischemic strokes that we usually observe in patients. Primarily, we have the atrial fibrillation, and then we have the carotid atherosclerosis that can eventually travel to the brain and cause the factors of the stroke in this particular patient. Sometimes it is the left ventricular thrombi. So it can be the valvular diseases, either it can be a rheumatic disease of the heart that leads to the thrombus dislocation from this particular site, and then it travels the cerebral vasculature. And on the other hand, it can be the most common cases that we usually observe in our clinics are the left ventricular thrombi that eventually travel to the carotid circulation, and then finally they pass on to the cerebral circulation over there. So this route is one of the most common routes that we usually come across. Then, of course, we have the group of diseases which are called as the valvular diseases, and it can be obviously the rheumatic heart valve diseases that leads to the formation of the thrombus and then the dislodgement of the thrombus due to the factors of atrial fibrillation. All of these are basically the contributing factors. Again, I would like to emphasize on the fact that history taking is very important in these patients, because whatever the case is, either it is the valvular heart disease or the ventricular thrombi which are dislodging and entering the circulation, the history is very important, and it can highlight very critical points, and it can basically point out towards a particular diagnosis in a patient. So when you take the history and when you take the past history, particularly the history of fever, whether if it is a septic thrombi, there can be a history of fever. If it is a rheumatic fever, a case of rheumatic fever, then obviously it is going to have been followed by a history of a high-grade fever. It can be a history of sore throat that the patient had experienced in the recent past. So again, the points are to be highlighted in the history whenever you have these cases and you want to look for the contributing factors or what caused the ischemic stroke in this particular patient. Then obviously, if it is a case of atrial fibrillation or atrial flutter, that can even contribute towards the dislodgement of septic thrombi, or even if there was obviously any previous thrombi that was present in the walls of the left ventricle or the right ventricle, it can be dislodged through this atrial flutter or the arrhythmias that are present in the patient. And that is one of the most commonest causes that we usually experience and that we usually observe in the clinics. The cardiogenic emboli then travel through the circulation. They enter the carotids, and they can be sometimes, if they are big enough, they are dislodged or they're lodged in the carotids. The examination over here plays a role. When you clinically examine these individuals, and obviously the examination is going to be started off from the general physical examination. You're going to observe the blood pressures in this patient, of course, and if it is on the higher levels, that is going to basically make the person more prone to the development of these thrombi and emboli in the circulation. Obviously, the patient is at high risk of this cerebrovascular accidents in this particular case. I'll be discussing the CHAT scoring later on. That is going to highlight the importance of the blood pressure monitoring in patients who are at risk or are prone to the accidents such as the ischemic strokes or even the hemorrhagic variety of the strokes. So the blood pressure monitoring is a vital and a pivotal part of the examination of patients of stroke. Then obviously you're going to carry out the rest of the general physical examination even in these patients, but you're going to pay special attention to the carotid bruit that is going to be highlighted in these patients. Whenever there is a lodged thrombus in either of the carotids, either it is the right carotid or either it is the left common carotid, if there is a dislodgement and if there is a lodgement of the thrombi in this vasculature, that can be heard through these bruits. So it's again very important to highlight these factors And obviously, you're going to carry out the Doppler scanning. If you hear these bruits in this particular patient, you're going to carry out the Doppler scanning just to view whether this particular patient is suffering from some sort of the common carotid artery blockage or not. And that is again going to make the patient more prone or at risk of the ischemic stroke variety in this particular patient. The next very critical step in the examination, it basically involves the examination of the heart, or we can also relate to it as the cardiovascular system to be examined in these particular patients. Now, what are you going to look for as a physician and as a clinician? What are the things that you're going to look for in a patient who presented to you with a particular history that resembles kind of an ischemic stroke, and you are referring or you're dealing this patient and you want to know what caused the ischemic stroke in this patient? You're going to look for the murmurs in the heart sounds. Now, the heart sounds are also to be heard at specific places. So knowing the examination and knowing the points of examinations are very pivotal over here. Knowing the surface anatomy of the heart and how you're going to examine the tricuspid, the bicuspid, the mitral, as well as the aortic valve has to be auscultated in this particular patient. If there are any positive signs for murmurs, as well as you're going to look for dysrhythmias. So these are the two pathologies that you're going to look for when you're auscultating this particular patient for heart sounds. So this is what I'm emphasizing on. You should know what you're looking for when you're conducting the CVS, that is the cardiovascular examination. On the other hand, obviously, the most important examination is the neurological examination. So you're going to carry out a detailed neurological examination and write down, document all of the pathologies over there. Basically, the highlights for the neurological examination are going to be the sensory examination, and then obviously that is going to be followed on with the motor examination of the patient. Then finally, obviously, you're going to look for the reflex examinations. Reflexes are conducted in these patients, and you're going to look for whether there are any signs of the upper motor neuron lesion or lower motor neuron lesions. Whatever the case is, you're going to document down the positive signs in this particular patient. So a detailed neurological examination is carried out for these patients of ischemic stroke. Again, when I'll be discussing the syndromes that are caused due to this ischemic variety of the stroke, that is going to highlight how, if a particular cortical area of the brain is involved, it can involve just the speech of a person. So it's again very important when you are looking for the gait and the speech and you're noting down all of these examinations in detail. It's again going to basically be a detailed examination in the patient. For instance, if it's the Broca's area that is involved, it is going to affect the motor aphasia in this particular patient. So you have to relate to these particular functional organizations of the cortical areas, and you should be well versed with these functional organization of these cortical areas. On the other hand, if it's the Wernicke's area, it is going to be enhanced in this particular patient with a syndrome which is known as Wernicke's encephalopathy. The patient can speak, the patient is able to speak in this particular variety of encephalopathy, but there is going to be a random speech. There's not going to be a coordinated speech in this particular patient. So having affected a particular area, and how is it going to affect and how is it going to have those positive signs, they're going to be related by the physicians, and that is again a very critical duty that is performed as a general physician or as a neurologist when you are examining these patients of ischemic stroke in your emergency departments. Then obviously you're going to carry out the lab investigations. Again, I'd like to emphasize the baseline investigations are to be carried out in all of the patients of emergencies. All the patients who report to you in the emergency departments, you have to carry out the baseline investigations, including the complete blood counts, the ESRs. There is going to be an elevated ESR in cases of infections. That is going to highlight the incidence of septic thrombosis in these individuals, or even it can be a case of bacterial endocarditis. So it's again very important how you basically synchronize the positive findings in the lab investigations with the patient whom you're dealing with. This is again very important that you have to note down as a physician and as a clinician. Then obviously you're going to look for any abnormalities in the serum urea, serum electrolytes that are conducted in this particular patient, and a very important test to be performed, which is the blood urea nitrogen, known as the BUN, for these particular patients. Again, it's very important to note down any abnormalities or any elevated or any below normal range levels that are noted down for these particular patients. Very critical and very important tests to be performed are the PT and the APTT, that is the prothrombin time, and the activated time for the prothrombin is again noted down for these patients, because the treatment guidelines that basically includes the life-saving feature of the administration of the recombinant tissue plasminogen activator. So before administering this important and life-saving drug to the patient, you're going to perform the prothrombin times, as well as the bleeding and the clotting times are to be noted down for these particular patients. And these are the most crucial and the most important tests that you're going to carry out in these particular patients. If there is a dislodgement of any sort of a thrombus in the carotids, either bilaterally or either it is a unilateral condition, that is going to cause a flow reduction to the cerebral vasculature. Again, we can perform the basically the carotid stenting procedure to relieve the patient of this carotid stenosis. So if you want to perform the carotid stenosis or even the thrombolectomies that basically requires a proper cut and a surgical procedure that are sometimes carried out for these particular patients. So sometimes it is an isolated procedure that you do for these particular patients, and sometimes it is coupled up with the other procedure. For example, if it was a patient of myocardial infarction previously, having a history of stroke in the past, and this particular patient is suffering from carotid stenosis, you're going to basically weigh the risk versus the benefit ratios in this particular patient, and then perform the stenting procedure, or then perform the thromboembolic procedures for these patients that would basically relieve the patient of this particular kind of carotid stenosis that he's suffering from. The carotid plaques with arteriogenic emboli, sometimes the plaques or the carotid vasculature, the common carotid artery, has an emboli which has traveled to this particular area through some other peripheral vasculature. So it can be even a cause of the ischemic stroke in the patients. Then obviously it can be a primary cause that generated intracranially. So it can be even a case of intracranial atherosclerosis that we're dealing with, and you should look for the features when you carry out the further imaging techniques involving the CT scans and the MRIs in these particular patients. Then obviously we have a lot of penetrating artery diseases. It can be the congenital form of the diseases that leads to the formation of plaques and atherosclerosis in the vasculature of the basically the main or the major cerebral vasculature, and that can even lead to a particular area of brain damage in these particular patients. So this can be the whole etiological factors, or on a broad spectrum when you classify the features or the causes towards the development of the ischemic stroke in the patients. The internal carotids, basically, they continue to form the middle cerebral artery, and that is why it can be one of the major artery that is involved in the development of the ischemic stroke. So one has to basically evaluate which particular artery is involved. Either it is the middle cerebral artery, the anterior, or the posterior cerebral artery. Mostly, we come across the cases of the posterior and the middle cerebral artery, and less likely it is a case of anterior cerebral artery that we're dealing with. Sometimes the thrombus can even dislodge from the external carotid arteries, and sometimes it can be a thrombus or a thromboembolic plaque that developed in the common carotid artery and eventually traveled to the cerebral vasculature to cause a particular area of infarct in the patient. So the cardioembolic strokes, as we discussed, it is one of the important variant or one of the most common cause towards the development of the ischemic stroke in the patients. The thrombus can basically be lodged initially in the atria and can even be lodged in the ventricles, and due to the atrial flutter and atrial fibrillation, it can be dislodged at any time, and basically the patient is at risk of the ischemic stroke. So this is the most important pathophysiology or the most important etiological factor that we have to consider. The atrial fibrillation in the left atrium is the cause of dislodgement in most of the cases that we usually come across. Embolus then basically enters the arch of aorta, and eventually it can enter the common carotid, the internal as well as the external carotid. And the final destination for this embolus is to travel towards the brain to cause an area of infarct. Common carotid is the next destination, the internal carotid, and finally, this diagrammatic representation is a beautiful way in which how this embolus can basically be traveled. But this is obviously not that simple as it is shown over here, but finally the embolus is going to block the blood flow to the part of the brain. So this is how you basically remember the whole pathophysiological factors or the events that take place before the infarct takes place in the brain. The affected portion of the brain is basically being shown by the grayish area as shown in the figure over here. The causes, the major causes, particularly the nonrheumatic causes that can involve the atrial fibrillation, and then we have the myocardial infarction. So you'd really commonly come across these patients who would give you a history of previous attack of strokes, or even a stroke, an attack of stroke is seen in patients who previously had an attack of myocardial infarction. So basically both of these conditions go hand in hand. Usually these patients are suffering from prolonged conditions, or they are the diagnosed cases to be suffering from hypertension, diabetes mellitus, and all of these are basically the risk factors towards the development of ischemic stroke or even the myocardial infarction in these patients. Then obviously the prosthetic valves is one of the major causative factors towards the development of cardioembolic stroke. And then we have the rheumatic heart diseases. So when we're discussing the non-rheumatic causes, we have the other causes that are not infectious in particular. But when we say we have the rheumatic heart disease, it's basically an infectious cause. We can also come across the bacterial endocarditis in this particular phase, and that can even lead to the development of a stroke in these patients. Ischemic cardiomyopathies is one of the related factors that these two conditions can also go hand in hand. The patient can suffer from an ischemic stroke either previously or even after an incident of ischemic cardiomyopathies. So what are the other, before we conduct the CT scans and before we move on to the other contrast endocardiographies that are performed for these particular patients, we obviously go for the CT scans and the MRIs, obviously, in these patients. And we want to highlight basically the watershed areas, the watershed ischemias that can be noted down for these individuals. And even we should know how to differentiate between these particular kind of hemorrhages. The echoes are obviously going to relate to the functioning of the heart. So that is basically going to give you a view of the valves, whether they're in a healthy condition or whether the patient is suffering from some sort of a valvular heart disease or not. Atrial flutters and atrial fibrillations are noted down at this level, and that is again going to highlight the pathophysiology or the etiological events that took place before the incident of stroke, and obviously contributed towards the development of ischemic stroke in a particular patient. The cardioembolic stroke, obviously, when you are carrying out the CT scans, whether in contrast or whether without a contrast, you're carrying out and you're looking for the watershed areas. What do we mean by definition to the watershed ischemic strokes? It's basically an area directly related to an artery in the brain. If you just look for the areas that are supplied by the middle cerebral artery, if the middle cerebral artery is blocked, and how would you know that the middle cerebral artery is blocked? You're going to carry out the transcranial Doppler scannings for the cerebral vasculature, and that is going to highlight which particular artery is blocked in this particular patient. And obviously, the CT scans are going to enhance the areas that are involved in the ischemic stroke. So you're going to synchronize again the areas involved in the stroke, the areas damaged, and then which artery was involved. So if the artery is not in direct relationship to the area, but still that area is affected, we can regard it to be the watershed ischemic areas of the brain. So this is one of the terminology that is used. And then obviously we should know how to differentiate between the frank hemorrhages, and then on the other hand, we have the particular hemorrhages, which is one of the features of the ischemic stroke. So it's kind of quite confusing. When you look at these particular hemorrhages on the CT scans and MRIs, you might confuse this kind of a stroke with ischemic variety, with the hemorrhagic variety on the other hand, but you should know that this is a particular feature of ischemic variety of the strokes on the other hand. So these are the features that which you're going to look for, the areas involved, and this is how that is again going to lead to a particular direction of the treatment towards the primary prevention and how you manage the case in a particular way. Then obviously we have the artery to artery embolic stroke. Mostly we do not come across the venous thrombosis. Usually it is the travel through the artery that leads to the development of a blockage of a particular cerebral vessel and resulting in a cerebrovascular accident ultimately. So this is a diagram showing a damaged area of the brain. And the vasculature basically involved over here, it can be a plaque that eventually arose in a particular artery, and a blood clot that was a part of that thromboembolic plaque. And that dislodgement of a blood clot towards the brain helps in the events that take place towards the contribution of the ischemic stroke in the particular patient. Small-sized emboli can even travel to the brain vasculature. So basically what happens, if it's a very small-sized emboli, or if it's just a blood clot that can resolve over a period of time, usually the patients suffer from transient ischemic attacks rather than a complete ischemic stroke. So again, it's very important when you define a transient ischemic attack, you should know what we're dealing with. A patient of transient ischemic attack is asymptomatic over a period of 24 hours. And the CT scans and the MRIs are going to show normal reports when you carry out in these patients of transient ischemic attacks, or which is abbreviated as TIAs clinically. So this is again very important how you distinguish, but still if it was a patient of TIA, you have to manage the case accordingly. to have basically the secondary prevention to be observed in these patients, blood pressure monitoring, lifestyle changes, as well as you're going to carry out the baseline investigations in these particular patients and then manage accordingly for the future. So this is again very important, how you look for and investigate in a particular case. Then obviously you're going to look for the artery-to-artery embolic stroke, or which is also known as the carotid atherosclerosis. It can be symptomatic. If it's not a TIA, then obviously it's going to be a symptomatic attack. And on the other hand, it can be asymptomatic after a period of 24 hours if it was basically just a transient attack suffered by a particular area. The risk factors, or the factors that you're going to look for in the history. So the gender of the patient, male are more predisposed to development of this embolic stroke. Older age, that is particularly when we're going to look for the CHAT scoring criteria. 1 point is given when the patient is over the age of 75 years. So it's one of the criteria that is used when we have these patients of ischemic stroke. Any history of smoking in the past, or what is the frequency of smoking, you're going to note down in the history. Hypertension is one of the factors, so you're going to monitor the blood pressure in these patients. Either the patient is a diagnosed case of hypertension or not, again, and if he or she is not a diagnosed case of hypertension, then a proper charting method and blood pressure monitoring is carried out for these particular patients. Diabetes, even it can be a type 1 or a type 2 diabetes, it has to be noted down. And obviously you're going to look for hypercholesterolemia. When you're going to carry out the baseline investigations in these patients, you're going to look for all of these criteria. These are the risk factors that make the patient more prone to the development of these cerebrovascular accidents. So this is very important to highlight in the history. The other causes, the less common causes, can be the embolic mechanism, the dissection of the internal carotid or the vertebral arteries. Then we have a type of a congenital disorder which is known as the Ehlers-Danlos syndrome. It's a connective tissue disease basically, related with the collagen synthesis, and that can even distort the blood vessels and make the patient more prone. So if he or she is a diagnosed case, you can highlight that in the history while you're taking that as a physician. Marfan's disease is very important if the patient is already diagnosed with, and you're going to look for the cystic medial necrosis and obviously the fibromuscular dysplasia. So the histology sometimes is going to reveal a lot of factors. If the patient is suffering from some sort of a collagen disorder that is distorting the vasculature, that is again very important over here. Trauma is one of the cause, and any recent trauma or any history of a recent surgery in the past is going to be highlighted as well in the history. The spinal manipulative therapies, it can be a surgical treatment as well as a medical treatment. If the patient had undergone, that has to be highlighted while you're taking the past surgical and the medical history from the patient. Then we can also come across the criteria which is known as the small vessel stroke. So if it's a primary condition that is arising in the cerebral vasculature, that can even cause the ischemic infarcts, and that can even highlight particular areas in these particular patients. The pathophysiology of the small vessel stroke, it can be related to the hypertension. So if you look for in the history or while you're carrying out the clinical examination, you monitor the blood pressure and you highlight that this particular patient is having the high levels of the blood pressures and he or she is diagnosed with hypertension, even the age. So if it is the older aged individuals that we are dealing with, it can result in the atherothrombotic disease in cases of hypertension, or it can be the hypohyalurotic thickening in cases of age-related disorders. Whatever the condition is, it is going to result in lacunes. So what are lacunes? And by definition, basically lacunes are these small subcortical hemorrhages or the infarct areas less than 15 millimeters that we usually observe on the, obviously the imaging techniques are going to highlight the presence of lacunes in the individuals. The two most primary factors for the development of this lacunar disorders are the age, and obviously if he or she is already a diagnosed case of hypertension or even a newly diagnosed case of hypertension, that is going to contribute towards the development of lacunes. Sometimes these lacunes can be symptomatic and sometimes they remain asymptomatic in these particular patients, but still you have to have a secondary prevention designed for these particular patients. If you have carried out the imaging techniques and you have diagnosed this patient to be suffering from this lacunar disorder, then you're going to make a particular management plan for these patients who are at risk of development of a small vessel stroke in the near future. The clinical manifestations involving the small vessel stroke, it basically includes the pure motor hemiparesis that can occur in the individual involving just the motor activities. And when you'll be conducting the sensory examination in these individuals, that is going to result in a normal analysis for these individuals, and it is not even going to affect the other sensory areas. It's just going to affect the motor areas, the motor activities, and primarily the reflexes of the individuals are either going to be exaggerated or diminished accordingly to the case. Then sometimes we have a pure sensory stroke involving or just affecting the sensory areas. So when you'll be conducting the clinical examination for the sensory examination, including the pain, temperature, the crude touch, the two-point discrimination, all of these factors involved in the sensory examination, they're going to be affected in these individuals. Then we have an ataxic hemiparesis in which there are the incoordinated movements that are observed for these individuals. And then finally, we have patients of dysarthria, that is the difficulty of speech, and a clumsy hand or arm. So this is the picture. It's as you can even observe over here, it's a Venn diagram. It can be sometimes a mixed picture involving slightly a sensory component, a motor component, speech areas, or it can be even coordinated with the ataxic and the incoordinated movements of the individual. So sometimes it's a mixed picture, sometimes it's the individual development of the hemiparesis in the particular individual depending upon the cortical areas of the stroke. As we know, there is a functional organization and the body mapping on the cortical areas. So it's again going to depend upon the typical cortical area damaged in the particular individual. The less common causes of the stroke, it can include the hypercoagulable disorders. So a lot of disorders that result in the hypercoagulability of the blood is going to result and is going to make the person at risk of development of ischemic stroke. Then we have the cases of homocystinemia, the venous sinus thrombosis. So there are a lot of disorders that sometimes result in the venous sinus thrombosis. And what are these particular disorders? It can be the congenital conditions usually. Sometimes the patients with foramen ovale and septal disorders are more prone to the development of venous sinus thrombosis. So again, it's very important to note down the diagnosed individuals or the diagnosed pathologies in a particular individual and just highlight them in the history, and that is going to contribute towards the analysis of the particular patient. The intravenous heparin is also going to be noted down. Sickle cell anemia is going to be noted down in the history. Fibromuscular dysplasias, patients of hypertension are more prone to the development of ischemic stroke in these particular patients. Sometimes the autoimmune disorders such as temporal arteritis, that is also known as a giant cell arteritis, also make the person more prone to the development of ischemic stroke eventually. Then we have the necrotizing arthritis. It is another variant of the autoimmune disorders over here. We have the idiopathic giant cell arthritis, which is another autoimmune disorder over here. Then finally, we have the primary CNS vasculitis in particular patients. Drugs like amphetamine are also making the person more prone. So drug addictions and any drug abuse are to be noted down. Posterior reversible encephalopathy syndromes and conditions like leukoariosis also predispose the patients towards the development of stroke. Now, what is CADASIL? CADASIL is basically the cerebral autosomal dominant arteriopathy. So this is a condition, a syndromic condition, which is also making the person more prone to the development of ischemic stroke. So it's basically a genetic disorder, and it is going to involve the chromosome 19 and also making the person prone to the development of ischemic stroke later in life. Now, sometimes we come across these conditions which are known as transient ischemic attacks that are caused due to all of the similar causes that we've already discussed, the common, the less common causes. They contribute towards the development of these accidents. The embolus and the thrombus, it can travel to the cerebral vasculature, block the vasculature of the brain and cause the infarcts, but the severity of the incident is less enough and less severe. So the condition basically resolves in a period of 24 hours. And when you carry out the imaging techniques in these individuals, that is not going to highlight any areas of cerebral ischemia or any areas that are damaged in particular of the brain. So these are the conditions which are known as the transient ischemic attacks. We should know how to manage these cases and also basically educate the patient that this was basically a transient attack, but all of the risk factors are present. So basically you educate the patient towards the lifestyle changes and all of the other apprehended changes that you can make in a particular individual. The risk of stroke and what are the clinical factors and what is the scoring system. So we have devised a chat scoring system that is basically going to analyze the risk of stroke in the individuals. We have these criterias. A is basically the age factor that is very important. If the patient is more than 60 years of age, that is going to give 1 point, that is going to add 1 point in the scoring system. Then we have the systemic blood pressure. If it is more than 140 millimeters of mercury, and the diastolic blood pressure is either more than 90 millimeters of mercury. So these are the two criteria when we are weighing this accordingly, and the score given for this criteria is a single point that adds to the score, that adds to the chat scoring system. The clinical symptoms, the unilateral weakness, that is going to enhance basically the transient attacks that are observed in the individual, and that is going to give out 2 points to the final scoring of the entirely individual or entirely to a particular patient whom we are dealing with. Then you're going to also look for the speech disturbances without weakness. So these are the two criteria that can give 2 points to the final scoring system. Then we have a single point for the speech disturbances. The duration is more than 60 minutes. That is going to give 2 points. And then we have 10 to 59 minutes. That is almost an hour. If the symptoms arises for this much of time, that is going to give a single point to the final scoring system. If the patient is diabetic or is on oral medications or even been administered the subcutaneous insulin, that is going to add a single point to the final scoring system in these particular individuals. Then obviously we have the total scoring system. If the total scoring system is basically, we add on this ABCD's total scoring system, that is 3 months rate of stroke attacks are diagnosed over there. If it's a 0 scoring system, then there is no risk that is involved over here. And if it's a 1, that is basically going to rate to the, that is going to rate the percentages to 2. And then we have a 2 score that is coordinated with a 3% chances of the stroke. A 3 score is indicating a 3% chances of the stroke in this particular individual. 4 is indicating an 8% chances of stroke in a 3-month rate. Then 5 is basically giving a 12% chances of stroke, and 6 is indicating a 17% chances of stroke. This is basically a categorizer method that we see, and 7 is basically giving a 22% chances of stroke in the individual. So this is one of the system that is devised. We have a lot of other systems. We usually come across the fact that these symptoms, the clinical symptoms, are important. The blood pressure monitoring is important. The previous history is important, and the age is important. So these are the important risk factors that make the person more prone, and we can even calculate the chances of stroke in a particular individual. So in this particular lecture, we summarize the condition of ischemic stroke and how can we basically evaluate and get to the particular pathophysiological events or even the risk factors or the actual etiology that is behind stroke and the ischemic stroke in a particular individual, as there is a range of causative factors that we have to choose from. Obviously, the history, the clinical examination, the lab investigations are the primary factors that leads to the investigation in a particular direction, and then obviously the final management as well as the secondary prevention is designed accordingly in these particular patients. So that is the end to this lecture. Thank you for watching sqadia.com.